So let me give you a scenario. So there are 8 preferred regimens in NCCN for relapse refractory patients. 6 of them are category 1. All but one of them are triple combination therapy. But there are some there's one that's all oral, the ixazomib, lenalidomide, dexamethasone, and one that the daratumumab, bortezomib is, plus the dexamethasone is all IV or sub-Q injection. One of those, the all oral therapy, could cost a patient $3,000 to $4,000 a month when they've blown through their donut hole. And now they have a 5% catastrophic coverage because those are oral drugs that are covered under Medicare Part D. So they could have $3,000 to $4,000 out-of-pocket cost a month. On the IV or sub-Q injection side, they could finish their out-of-pocket cost very quickly, especially in a Medicare Advantage plan, and have no cost because they've met their out-of-pocket maximum. Does that ever influence, that situation ever influence what your preferred regimen is in treating your patients who have relapsed refractory disease?
That's a very good question. Usually the patients bring that forward because we come up with a treatment option and you put a plan into place. Yeah. And patient doesn't know, the physician doesn't know. They listen to you and you think you are creating a good program. Yeah. And they go. Then afterwards, you start getting phone calls back,
Right.
And
but do you even present those options?
Change.
Yeah. Do you present those options to patients? And say we've got an all IV or sub-Q versus an all oral?
No. We do present the option because, as I said, some patients, older patient, cannot travel back and forth. Coming into Mount Sinai, even if they are in Queens, for an 80-year-old person, they are dependent on somebody else also coming and things like that. They can't just pick up a Uber service and come every time because that adds to the financial toxicity too. And some other patient have to have a family member, a son or a daughter has to take up. So all of that is play. So you do discuss about all oral regimen, IV regimen, things like that.
Are you incorporating cost in those discussions? And if you're not, should you?
Okay, no, that's a good, because to be honest with you, I really do not know the financial toxicity that's going to happen to that patient per se. So we discuss about the convenience and the toxicity provide and what they prefer. Then they go back home and the order is put on. Then I get a phone call.
Get the phone call.
Then
right.
Then immediately you respond to it. So yes, we do address it because this is real world, and these are real patients, and I'm here to care for the patient, no matter what the circumstances are.
So we're blessed because we have a plethora of treatments now in the relapse refractory setting, but they have their clinical benefits and they have their clinical toxicities, and they also have financial toxicities. And I think especially now, because of those financial toxicities, because of these combination therapies given over many years, is it incumbent upon us to make sure that we ask those questions up front rather than prescribing a therapy that the patient can't take because of those. So I think it's a fair question, and I think in the OCM model, in the oncology care model, physicians are required, that's part of their care plan, is to discuss those financial toxicities to help ensure that before we ever start therapy, we know that the patient can take it.
But I think these are great perspectives, and I agree with that. But I think from a treatment perspective, being in a busy clinic, the patient is sick, you need to make decisions, you have more patients waiting, you have to do the best.
Well, that doesn't mean the physician has to do it, but are we doing the best thing for our patients if we're not asking those questions?
So what I was about to say is that the physician, I think, should make the decision early on, because if the physician makes the decision, even if other people jump in later, I think it's too late. So when the decision is made or when the different options are presented, if you don't have that information, everything appears equal, and it may not be equal. Yeah. I think this is a big problem in real time in the clinic, that the patient doesn't know what his or her kind of copay will be, and the doctor doesn't know, and you strictly look at the data, you look at the different options, and then you make a decision on that. And you maybe would have made another decision if you had that other piece, but it's just not there.
Yeah. Well, we won't come to consensus on this, but I would say that if you didn't have a critical piece of lab data in order to make a treatment decision, you would get that. And I think in the future we need to consider that as a critical piece of data in making a treatment recommendation to patients if we want to ensure that they get the optimal outcome, to make sure that the patient doesn't stop at 9 months because they can no longer afford the drug and they're afraid to tell you that they can't afford it.
My pushback to it, the lab data is if I give the blood, I get a fixed lab data.
Yeah.
But in the other side, I don't have a little web or this thing which kind of says this is a patient, because they're all registered up front, right? So they have taken the insurance. But I don't have a computer program or an app which says this is the patient. Oh, you type in carfilzomib, pomalidomide, dex. This will be the patient's cost.
Well, the cool news is that it's available.
It.
It's coming, just like new drugs are coming. That will be available to you. So I think this is a whole new age in terms of not only the options that are available, but trying to understand how to get the best outcome for a patient.
With information.
Transparency around the cost.
I think it sounds very
Yeah,
good.
that
Sounds like
very
the
good.
right way to do it.
Yeah.